USC, Los Angeles County Hospital, did my general cardiology fellowship in Dallas, and then most recently did a additional year in heart failure and transplant in Seattle, Washington. Just joined our program over here at UC Irvine. There's my email address if you have any questions about the lecture that you would like to address privately. Feel free to shoot me an email, and we'll go ahead and get started, okay? So I don't have any disclosures to report. This is an outline of our talk here. Today, we're going to be talking about advances in the treatment of heart failure. Overall, we'll just talk a little bit about what heart failure means, what are the mechanisms involved. From there, we'll move on to an overview of established therapies. So what exactly is conventional? What do we do currently? From there, we'll start talking about emergent therapies for heart failure. There has been exciting new development, and I think it's worthy to talk about because soon you may see it on the internet or on CNN or some other news channel. So it's kind of nice to be able to go through that before it hits the press. And finally, we'll talk a little bit about treatment for end-stage disease as well, which, God forbid if you have that, but it's something that, we're still trying to work on to figure out how to take care of those very sick patients. So as a background, heart failure, what is it? It's a condition in which the heart is unable to pump enough blood to circulate the body. It can be due to a stiff heart. It can be due to a weak heart. It can be due to multiple different problems, the most common of which is either ischemic cardiomyopathy caused by heart attacks. It could be due to a genetic cardiomyopathy, where there are just genetic mutations that affect the way that the proteins in the heart function. Sometimes people do get heart failure from toxins such as chemotherapy or other drugs. In very rare circumstances, some folks do have congenital heart disease. And then finally, there's a whole nother spectrum that we're not talking about, which is heart failure with preserved ejection fraction. On the right side, you can see there's a illustration here about what does heart failure really look like. There's diastolic heart failure. The walls are just stiff and thick, and when it tries to fill up with blood, there's just not enough space. It can't fill up with blood, and as a result, it isn't able to provide enough blood flow. And then there's systolic heart failure, which is the main focus that we're talking about today, where the heart is just dilated, enlarged heart. It gets so stretched out and thin and weak, and the chambers all just become blown up like a big balloon. So as far as heart failure itself, the heart and the body have compensatory mechanisms to counteract this condition, and that's what we call a heart failure syndrome, and we'll go into that in more detail next. So these are some statistics about heart failure. It's increasingly prevalent. Heart disease, it's kind of evolved over the past 40, 50 years. Most of the morbidity and the mortality attached to heart disease was due to heart attacks. However, we've gotten pretty good at treating people with heart attacks. So those people who originally would have suffered, a fatal event from a heart attack, they're living longer. As a result, as adults get older, heart failure continues to increase in prevalence. Between 2013 and 2016, there were about 6.2 million adult Americans with heart failure. And over the next 10 to 15 years, it's expected to exceed 8 million people. There's a breakdown here on the right, but you can see that overall patients that are older than the age 60 make up a substantial portion of these patients with heart failure in the population. Risks of heart failure increase with increasing age. Once you get past the age of 45, the lifetime risk of heart failure can be anywhere between 1/4 and 1/2. So it's something that we really need to watch out for. There are risk factors involved, like we talked about with heart attacks, patients who have hypertension, obesity, coronary artery disease, diabetes, tobacco use, Those same risk factors which increase the risk for having heart attacks are shared in patients that develop heart failure. So now, where does this all start? I don't know if you guys know what this is, if you're any plant appreciators in the audience, but this is the foxglove plant, which is a digitalis. Okay, pretty interesting actually. It's a stunning flower that's native to Europe and the Mediterranean, but it's propagated throughout America now. I used to see it while just hiking up in the Northwest, but as beautiful as this plant is, it has a historical reputation for having healing properties for both epilepsy and dropsy. Dropsy is like the ancient term for heart failure. It really stood for hydropsy, but really it's just edema. Okay, so Dr. William Withering from England, he published this case series back in 1785 of hydropsy patients that were treated for edema. He recorded 162 cases of heart failure, and he treated them all with digitalis, which is and well, guess what? This drug is still around. Isn't that amazing? So this is also just a fun fact. Van Gogh, the artist, he actually had epilepsy, and it was thought that he may have been treated for his epilepsy with digitalis as well. And that's why his paintings use those vibrant yellow colors. Because when you get poisoned with digitalis, you kind of just get a little yellow and blurry vision. So overall, this was that manuscript from back in 1785, and it's still kind of relevant today because standard therapies before the 1960s, before science took over and we really started to understand this condition, people used digitalis, which is now digoxin. They used mercurial diuretics, so mercury-based medications that would also cause you to urinate more, and that would help with the dropsy or the just overwhelming edema. Nitroglycerin, which is a compound found in dynamite and gunpowder. People actually took that, and that tended to help with their condition as well. Bloodletting, well, you can always bleed the disease away, and that's what people did before these things were really well understood, is just by phlebotomy. So overall, people have kind of figured out, this is a way of improving the condition, but what is really causing it? And that's where science took over in the 1960s until now. We really started to understand what exactly the heart failure syndrome was. So as our understanding for the human body physiology expanded, we identified there's actually multiple systems that participate in the heart failure syndrome, both as a consequence and as well as trying to compensate for that weak heart. So this is an illustration from a journal back in 2012 where they show all of the different interactions that these different organ systems can have. So the heart, the kidney, the endocrine system, the immune system, the central nervous system, so the brain, spinal cord, all of these different parts of the body communicate with each other in the heart failure syndrome. So the most important that is shown between the heart and the kidneys is the renin, angiotensin, and aldosterone system. This is the hormone system that the heart and kidneys use to communicate each other. When the heart's stressed out, it upregulates these hormones, and the kidney kind of understands that, and it tries to help compensate for the weak heart. But also, especially with very bad heart failure, adrenaline is released. The adrenal glands release adrenaline, epinephrines, aldosterone as well, and it causes that weak heart to work harder. It really like flogs the heart, but it's doing this just to try to improve the overall condition. Inflammation, it actually helps adapt the heart and the kidney to the high stress state. This is still something that's being worked out, but it's certainly an important contributor. And if we can get this inflammation under control, then patients tend to do better. overall, these are all potential targets for therapy, and we've incorporated these into the standard practice for treatment of this condition. So these are guidelines from the American Heart Association. We don't need to get into the nitty gritty about all of this, but overall, from 1960 until now, we've slowly understood just a little bit more about how to take care of patients with heart failure. And it goes to show that as we grow our pool of knowledge, we're going to continue to identify therapeutic interventions that may help patients with this condition. So just kind of breaking down what those therapies are. These are all the standard therapies in 2020 in that guideline recommendation. ACE inhibitors, angiotensin receptor blockers, and then these newer medicines called neprilysin inhibitors. These are all kind of in the same class of medications. The neprilysin inhibitors are Entresto, which you probably have seen commercials for on the TV. But overall, they all work in a similar way to help regulate the hormone changes that affect the heart and the kidneys. Beta blockers, this helps to control that epinephrine, the adrenaline release that the stressed out body has. Once you can control that adrenaline release, the heart tends to respond to it and eventually improve. There's some other medications here: mineralocorticoid receptor antagonists, hydralazine isosorbide, digitalis. See, again, with that foxglove plant, this intervention is still out there. You can still buy it at Walmart, so it's still available. Ivabradine is newer medicine, and then implantable defibrillators and cardiac resynchronization therapies are all things that are, standard of care. If a patient needs it, then it is indicated. But wait, there's more, because just like how 2020, surprises us month by month, so does the progression of heart failure research. So this is a pretty crazy slide. There's a lot of things going on here, but I really just wanted to emphasize the fact that science is not so simple. With every new discovery, there's even greater unknowns. And because of this, like, the scientists just keep on trying to add to this pool of knowledge by understanding the interplay between the heart and the rest of the body. All right, sorry, someone muted me. Hopefully we didn't miss anything important. So going to this, there are both incidental and coincidental therapies that we found to be beneficial for the heart failure syndrome now. I'd just really like to go over, some of the new discoveries that folks in the pharmaceutical industry and translational science industry have made. These are the up and coming therapies that you may see advertised on TV or else written about, and hopefully we can continue to improve the outcomes of our patients. So the first medication that, this is a big deal to us in the field. I don't think that it has really gotten out into the public quite yet, but SGLT2 inhibitors, these are the sodium glucose transporter type 2 inhibitors, which have recently gained some traction over the past decade. So just going into the science a little bit, SGLT2 channel, it actually absorbs sodium and glucose from the urinary filtration system in the kidneys. So as you may know, kidneys filter toxins and help regulate chemical balances within the body. And in general, it helps to, expel all of the toxins into the urine. So it filters out the bad stuff and hopefully gets it out of the body. Well, with diabetes, people who normally have regulated glucose have elevated blood sugar. So the thought was that by blocking this transporter, diabetic patients would actually be able to control their blood sugar levels by just urinating all of that sugar out. So that can reduce their blood sugar, it can improve their glycemic control, they can use less insulin, they can have better outcomes. Sounds like a great idea, like overall, over the past 30 years, diabetes care, the medications, although effective, they really haven't shown to be greatly beneficial in reducing morbidity and mortality. So um, now with this latest push, they've nailed down this as a potential new agent. Well, great idea. What is even more interesting is that when they were trying to get these drugs approved as a part of the FDA regulatory approval process, um, they need to actually look at the cardiovascular endpoints to prove that these drugs are not harmful to the heart. The reason for this is that in the past with some other diabetes medications, they lowered glucose, but at the same time, the patients end up having more heart failure and more heart attacks. So they realized, we actually need to make sure that this doesn't happen again before we approve the drug. So with the first drug, which is actually empagliflozin, they showed that the patients being treated with this drug for their diabetes, they actually had better outcomes for their heart disease. They had fewer heart attacks, they had fewer heart failure events. It was almost serendipitous. So then they launched the cardiovascular trials, specifically looking at how do these drugs, affect heart disease. First, they looked at the diabetics, then they looked at non-diabetics. And what they found was very exciting, actually. These drugs, which treat diabetes, also help the heart and also help the kidneys. This is like a nice little flow chart showing how does this help. So as we talked about, by inhibiting this channel, the patient pees out sugar. So that helps actually with weight loss. It helps them burn calories, so to speak, weight loss, reduction in the epicardial and visceral fats, and that helps with heart function. Also, by controlling blood sugar, it reduces inflammation, and it also kind of helps to reduce the toxins, uricosuriya. So that's just your uric acid going down, which normally causes gout, but is also associated with just cardiovascular and other unfavorable outcomes. So that's an interesting thing, but also not only does it expel the body from glucose, but it also expels sodium from the body. So that has an entirely different spectrum of benefits. It helps with blood pressure. It helps with those hormones, with the adrenaline release. It helps reduce the overall body fluid level, which again helps with heart failure. So this is a very serendipitous finding. And as we learn more about these drugs, we'll find that they are going to be pretty beneficial. And slowly, they're probably going to make their way into the heart failure guidelines. And these are the drugs that are currently on the market: empagliflozin, which is Jardiance; dapagliflozin, which is Farxiga; canagliflozin, and sotagliflozin. They're all flozin drugs, but they all work pretty well, and they're all about the same. There's a class effect here. So just going into the more novel therapies, like this is something that has come up quite recently. It's called vericiguat. It is a soluble guanylate cyclase stimulator. It works by a completely different mechanism compared to what we had previously known about heart failure. It actually modulates the endothelial cells to produce more nitric oxide. Nitric oxide is just a for the most part, positive molecule that once it hits the bloodstream, it helps open up blood arteries and it helps with circulation. So it's thought that by improving nitric oxide production, it will allow the heart to pump blood easier. They released the results of a relatively novel trial where they actually looked at fairly high risk heart failure patients, and they showed that with this medication, they were able to significantly reduce heart failure hospitalization in this patient group without really any negative or adverse outcomes. So this is something that's still kind of on deck. It hasn't been approved by the FDA yet, but I think that overall there may be a target population that may benefit from this medication. Omecamtiv mecarbil. This drug just recently was presented a few weeks ago at the American Heart Association conference. It's probably got the coolest name I've heard for a heart medication, and it works even more differently compared to what's been available thus far. So instead of modulating the, you know, uh, heart cell chemistries or by affecting the hormones or adrenaline, things like that, it actually directly activates the myosin filament of cardiomyocytes. It helps the heart muscle cell bind the muscle fibers even stronger and creates more force during the power stroke. So it's like, it just sounds like a horsepower kind of thing. But it has a very novel mechanism. So this, in theory, it should allow for more efficient heart muscle activity, and it avoids the nasty side effects that we typically see with drugs that try to accomplish the same task. Um, so it's shown some benefit, but there is definitely more to come. It was just presented a few weeks ago. It's not approved by the FDA yet. It probably has some benefit in the population like we talked about. So, like as these different pathways get discovered and a scientist or a drug company makes a new intervention, we just keep coming up with new stuff. And after a certain point, like, what's the right therapy here? We have some guidelines to guide our treatment selection, but in the end, we still got to really iron this out. And this is where it is pretty exciting that being a part of a heart failure practice, and we'll be able to see how all of this unfolds in the future. So, there will be more to come, but it's just going to take years to really get it sorted out. So this is just for the data-driven folks. It's a comparison of all of the different landmark trials that have tested out these drugs that I had listed on the previous slide. This was put together by Dr. Fonarow, who is a world famous cardiologist in heart failure population research over at UCLA. What he did was, on the x-axis, he plotted the all-cause mortality for patients in the placebo or active control groups. And then on the y-axis, he plotted this against the relative risk reduction that was shown in the intervention arm for each of these specific trials. So it takes a little bit of time to digest what all of this means, but I'll kind of go through the basics with all of you here. So the landmark studies of renin-angiotensin-aldosterone inhibition, as well as beta blockade, those are those well-defined standard therapies that we talked about on the first several slides. They show the greatest benefit in high-risk patients. That is the top right, spironolactone, the top, which is carvedilol, which was the Copernicus trial, bisoprolol was CBIS-2, metoprolol, succinate, which was the MERIT-HF trial, like all of those ones on the top that you can see. Those are the trials that showed some of the greatest benefit with these medications. And the reason for that is that because overall these landmark studies were tested in both high-risk patients, of course, but also with the lack of background therapy. So those guidelines that we talked about, they weren't available back when these trials were first going on in the early 1990s, okay? So overall, we've really made great progress in trying to tease out which drugs are beneficial. So, okay, that being said, we figured out what are the most beneficial medications. These became standard therapy. Now, kind of look in that middle section, sacubitril, valsartan in the Paradigm-HF trial, dapagliflozin, that new SGLT2 inhibitor that we talked about. These drugs required standard, or these guideline directed medical therapies as background therapy. And then they tested the new drugs on top of background therapy. And that's why the overall all-cause mortality in the placebo or control group was not as high as those other trials, but at the same time, it still showed substantial risk reduction with these interventions. So really, sacubitril, valsartan, dapagliflozin, very impressive, because in the modern day area with modern day era with standard background therapies, it still shows substantial risk reduction. And then those novel drugs, the ones that we have shown some benefit with the phase 3 trials, but it has not quite yet been approved by the FDA. Where do they stand on this whole spectrum? They're the ones on the very bottom, vericiguat, which is the Victoria trial, Omecamtiv mecarbil, which is the GALACTIC-HF trial. Very bottom of this chart is where you can see that overall, they did not exhibit great risk reduction in mortality, but what they did do was reduce heart failure hospitalization. So overall, I think that this chart will help us decipher, what therapies we would preferentially like to start. And then, of course, the guideline writers will be the ones that say, hey, take all experts together, and this is what we need to be doing. So with these multiple available therapies, I believe that tailoring the therapies, individualizing them towards a patient's risk profile will be very beneficial in the future. We're going to wait to see what prospective registry analyses show, deep phenotyping, machine learning. This is where all of the biomedical engineers, all of the computer science geeks and epidemiologists can all get together to really help us understand, with these different therapies, how do we overall improve patient care? So let's just take all of these medical therapies, just lump it in, okay, well, we got it now. We're kind of tired about talking about medical therapies. What else do we really need to be aware of in the future? So device therapies. This one's kind of interesting. I just kind of popped it in here, even though it's been around for a while, actually. The wireless pulmonary artery pressure sensor, the brand name is the CardioMEMS device, which is manufactured by Abbott. It was actually St. Jude, and it was another startup company before then. Just a kind of a interesting side fact. This was actually a MEMS device, which is a microelectronic machine which measures pressure. And they used to use this sensor to measure pressures in oil tanks. And then a grad student at Georgia Tech decided, hey, maybe we should try to apply this to the biomedical field. So he took this MEMS device, put it in a person, initially tried to use it to measure aortic pressures in aortic aneurysm patients, and then toss it around one of those incubation thought tanks. And overall, they decided, hey, this might actually work really well in a heart failure patient because it can tell you the same information that a heart cath does, where we measure the blood pressure in the heart and the lungs. And thus this device was born. It got bought out by this huge now, medical device company, Abbott, and they're really able to use it to help out our heart failure patients. What it can do is that it's just a little induction circuit that measures blood pressure and deforms based off of how high the pressures are. And you can read what those pressures are with this electromagnetic field pillow, and it uploads it to the internet. So then you can just go online and see what the pressure is in the heart and the lungs. Pretty cool, right? I think that with patients that are frequently in the hospital, or those that just have very difficult to control heart failure, this device does have a purpose, and they are still conducting trials to see how beneficial can this device really be in terms of reducing not only heart failure hospitalization, but also cardiac mortality. So more to come on this one. So advanced therapies, this is what we went into training. This is what we really like to try to improve, because it kind of goes both ways. Heart failure, some unlucky folks do progress to end-stage heart failure where they do need advanced therapies, but we also want to do our best to try to prevent this from happening. So once someone does get to hear, well, what do we do next? What is there to offer? And that's what we'll talk about here. So in terms of advanced heart failure, the disease trajectory, it's pretty similar to progressive cancer, actually. So this is a graph that was published in a palliative care journal in Canada, actually, where they compared, hey, this is where the cancer trajectory is, and this is what the end stage heart, and then also end stage lung failure trajectory. And overall, it's horrible. Like nowadays, rightfully so, cancer is a horrible disease, and there's been a lot of public attention on trying to prevent cancer, trying to cure cancer, trying to eradicate cancer. Um, Honestly, like within our field, we wish that there was that same emphasis on patients with heart failure, because it is also very horrible. And if you do not catch the patient before that downward spiral, as you can see towards like the tail end of that graph, it's not a good outcome. So this is where certain advanced therapies come into play: heart transplant, mechanical heart pumps, left ventricular assist devices. These have been around for actually quite a while. It's sort of been the holy grail ever since the end of the Second World War and during the Cold War, where as we started to understand how to take care of heart patients, the world famous cardiac surgeons, Michael DeBakey, Denton Cooley, they tried to develop mechanical heart pumps as well. So these are some of the examples of the evolution of these heart pumps. There was the HeartMate XVE, which, gosh, that thing is probably the size of a cantaloupe. It was pretty big, but that was actually a fully implantable, durable left ventricular assist device that was able to keep patients alive until they made it to heart transplant, or in very rare circumstances as a destination therapy. But as you can see, these pumps, they went from being enormous to almost something that's, palatable, like, hey, we might actually be able to do something with this in a large population of patients now. So this was the XVE, this like a cantaloupe. This was actually a pulsatile left ventricular assist device. So what it did was it would inject air into one end, where that tube you can see is. It's a pneumatic device that actually pushed the blood out of the pump and thus created a pulse. And then for diastole, when the heart is relaxing, it would try to simulate that by sucking that air out and then allowing the chamber to fill. So it's a pulsatile left ventricular assist device. Thing was a beast. It caused lots of strokes, lots of bleeding. Not any fun. Like, it gets the patients to the transplant, but really it's not a great way to live life. So as technology got better, we were able to really reduce the form factor. We were able to perfect the type of pump it was. This is for the mechanical engineers out there. The HeartMate 2 is an axial flow device. The picture's a little small. I must apologize for that, but pretty much it's a little rotor that spins continuously, thus allowing for a continuous flow in from one end and out to the other. This was a game changer, honestly, because it was not only a bridge to transplant, but eventually patients could actually leave the hospital with this device, still maintain decent quality of life while they were waiting for a heart to become available, or if they were not candidates for transplant, to just live out their remaining days and accomplish what they wanted to do before ultimately passing away. The HeartMate 3, this is the latest iteration, where instead of an axial pump, it's actually a magnetically levitated centrifugal pump. So it kind of uses magnets to rotate a rotor, and then it would actually pump blood that way. So this one we'll talk about in a little more detail later. So this was the LVAD that probably the most famous LVAD patient that is in the world. I think Dick Cheney, the former vice president of the United States, he was actually, he had ischemic cardiomyopathy. I believe he had 2 coronary artery bypass surgeries, still had a very sick heart, and ultimately needed a mechanical heart pump, the HeartMate 2, as a bridge to transplant, which he eventually received. But he was in a news interview, which they actually show that he had an LVAD and he was still thriving on it. So overall, I think that's pretty impressive, and that's where it drew a lot of attention to people. So Survival on LVADs have actually improved, like we showed the HeartMate XVE, which was that big clunker. But even that was still better than medical therapy for end-stage heart failure. So you can see here Dr. James Feng, who's over at University of Utah, but he put this graph together back when he was at Harvard Medical School. He shows that from medical therapy to pulsatile flow LVAD, which is a HeartMate XVE, to continuous flow LVAD, there has been this improvement over each era of the device. And keep in mind, this is 2009. It shows that over 2 years, there was about a 60 to 70% survival with the HeartMate 2 LVAD. Nowadays, with the newer device, which is the HeartMate 3 or the HVAD, the 2-year survival is about 80%. So it's getting comparable to heart transplant, but only within that 2-year endpoint thus far. So these are the contemporary devices like we talked about, the HeartMate 2, which is axial flow. Heartware HVAD is a hydrodynamic centrifugal pump, and then the HeartMate 3, which is the magnetically levitated centrifugal pump. So overall, these devices, they are getting better. There's still work to be done, but it offers a actually bright hope for patients with end-stage heart failure as they get the appropriate care that they need. And then this is just a picture of how each of these pumps look like. So you can see overall, they're pumps that have an inflow cannula and outflow cannula. The inflow cannula attaches to the tip of the left ventricle. The pump, which is exterior to that, pumps blood, sucking blood out of the left ventricle and then injecting it out of the outflow cannula into the ascending aorta. So overall, same concept, different devices. Since these are all mechanical heart pumps, they require an external power line, what we call the drive line. And then the patient actually has to wear batteries in order to keep their mechanical heart pump powered. Otherwise, they're in deep trouble. So overall, there's still work to be done. Can we avoid having patients wear batteries all the time? Can we avoid having a drive line protruding from their abdomen? Because that does create not only it's not only not great cosmetically, but more importantly, it can possibly cause infections. So we really would hate that to happen. And there's still much work that needs to be done in order to make this device into something where really it's a heart off the shelf, because it's not a heart off the shelf really. So this is just a proof of concept, if anything else. The Journal for Heart and Lung Transplantation showed that there was a wireless coplanar energy transfer. So they used radio frequency in order to charge up this device and keep it running. So they no longer have a drive line, but they still have to wear battery pack around, a bunch of mechanical devices. I mean, I think this is something where they're considering it the holy grail, and that it is a potential heart off the shelf that someone can just live with forever, but we're not there yet. The artificial heart, we won't get into too much detail because this is this is pretty gnarly. It's a artificial heart which has been in development since the 1980s. The original device was called the Jarvik heart, or the Jarvik 7. Jarvik, I believe, was over in Utah. Either way, this thing, it's a pneumatic powered diaphragm, which allows for the filling and injection of blood into these rigid plastic chambers. So in order to replace the heart with this artificial heart, you have to actually cut out the left ventricle, cut out the right ventricle, and replace it with this plastic container. So it's essentially Tupperware. It really is just Tupperware. And then it has mechanical heart valves, both between the atrium and the artificial ventricle, and then between the artificial ventricle and the great vessels, either the aorta or the pulmonary artery. So wow, right? It hasn't changed all that much despite it being around for the last 40 years, certain centers still use it in efforts to, as a bridge to transplant for the most part, when the patient just is so unstable, they need something in order to keep both sides of their heart going in order to make it to transplant. That is where this device has its true utility. But it is something that it's not an advance per se, but it's still available, and we're still using it now. And then heart transplant, just a little bit about it as well. First performed in South Africa by Christian Bernard in 1967. Dr. Shumway performed the first heart transplant in 1968. Nowadays, there's more than 3,500 heart transplants performed worldwide every single year. It remains the gold standard for durable treatment of end-stage heart failure. The survival's very good. Average is out to be 17 years. Typically, if the patients make it out the first year or two, they have great outcomes, great survival. And up in Seattle, we were seeing patients 30 years out from heart transplant. So it's actually still around. It'll probably stay around until something better comes along. So it does require blood type and antibody match because it is a different person's organ. So your body does not want to accept it. It wants to reject it. And as such, long-term immunosuppression is required. But heart transplant, why has it stayed so small? Only 3,500 cases worldwide per year. And then all of these mechanical heart pumps are hitting the market, and all these people are getting mechanical heart pumps instead of transplants. Well, it's because the donor pool just has not gotten much larger. Okay, so overall, less people are dying. People who, especially with potential donor organs, they usually like to take it from younger people who get in car accidents and bad things like that. But fewer people are having that. So in order to expand the donor pool, we've looked at several potential options. There's PHS high risk. So this is a graph where pretty much the opioid epidemic, that's a horrible thing, like OxyContin, fentanyl overdoses. There are a lot of organ donors out there that are now, they're becoming organ donors because of fentanyl overdoses and the opioid epidemic. What does that mean for the donor pool, though? So these patients who may have died from drug overdose with a needle in their arm, or have engaged in other high-risk activities, they have not traditionally been accepted for heart donation or heart transplant. However, nowadays we're starting to try to figure out, hey, like these organs may actually be useful in expanded donor pool. And as you can see from 2005 to 2013, slight increase, but after that, like 2014, 2015, 2016, as we started to consent heart transplant recipients for these high-risk donors, we've really been able to expand the donor pool. Hepatitis C kind of follows along with the drug epidemic, but a little different too. Hepatitis C historically was either an incurable infection or a very difficult to cure infection. Back then they used to use interferon gamma, which was like a horrible medication, horrible side effects. Lately, with the newer antiretroviral medications to cure hepatitis C, Harvoni, Mavorite, these new medications actually are very successful, well tolerated, not terribly expensive. So some, to be honest, very creative heart transplant programs proposed, why don't we try transplanting a patient with a hepatitis C positive heart, and if they end up contracting hepatitis C, we can treat it later. And they've actually shown that their results have been good so far. This started maybe about 4 or 5 years ago. and periodically publish their results. This is a result from 2020, which showed that 1 year survival's about the same as hepatitis C positive or hepatitis C negative. So more to come on this, but this will be able to substantially improve the donor pool. Finally, DCD, donor after cardiac death, kind of a morbid discussion. I hate to get into too much detail here, but we call it the heart in a box. Sometimes potential organ donors, the consenting family, they want the patient to pass away naturally. They don't want them to not be, not have cardiac death before harvesting the organs. So what they can actually do is allow for a natural death. And then once that death has occurred, they can harvest the organ, resuscitate it, put it in a box, allow it to perfuse, and then use it for organ donation. And it's been thought that this technique can increase the donor pool by 30%. So we will see. San Diego's doing it now. University of Wisconsin's doing it. Duke. All of these major transplant centers are getting in on this, and it may be something that will be able to substantially improve transplant volumes. So in conclusion, medical therapy for heart failure continues to develop. Like we talked about, there's multiple potential treatment targets that offer opportunities to individualize patient therapy based on what their phenotype is. Device therapies continue to evolve, and they may play a future role in patients refractory to medical treatment. End-stage heart failure, it may be inevitable, unfortunately, but durable LVAD devices may play an earlier role in treatment as a means to reduce mortality. And in the end, heart transplant remains irreplaceable as a definitive therapy for end-stage heart failure. And so that concludes my talk. I just wanted to remind everyone to wear a mask, slow the spread. We're all getting hit pretty hard here. So, you do your part and we'll do ours. Thank you so much.
Okay, thank you, Dr. Lee. If anyone has any questions, you could type it into the chat or raise your blue hand, Zoom hand, and I'll call on you and have you unmute your audio. There is a question in the chat right now. What is the treatment for an enlarged heart?
Yeah, well, that's what we tried to cover, but it really comes down to those first very few slides. Let me see if I can get over to it. Why is the heart enlarged? What can we do to reverse that process? Because in the end, that is, what we want to do. Medications, they're great. If people didn't have medications, they wouldn't be able to thrive. So really, in terms of treating an enlarged heart, we want to identify patients who are at risk for developing an enlarged heart. Once we identify it, do our best to prevent it from getting worse. And if patients are truly symptomatic, we want to accomplish three things: help with the symptoms, help reduce hospitalizations, and ultimately help the patient live longer. So overall, it's all about identifying and then getting them in to see us in clinic, and we can get you on all of the right medications.
Okay, does anyone else have any other questions for the doctor tonight? You could raise your blue Zoom hand, or and I'll let you unmute yourself, or you could type it in the chat. Okay, I'm not seeing any more questions here, so I want to thank you, Dr. Lee, for coming out tonight and giving this presentation. I'm sure it'll help some of the people out here. I know, being in the 55 to 90 plus age group, this is probably a concern for a lot of the people. We do have another question in the chat. Does diet and exercise help with coronary heart failure?
Does diet and exercise help with coronary heart failure? I love diet and exercise. I think that, in terms of prevention, especially primary prevention for cardiac disease. That is something that we need to talk about, emphasize as within the community. Now, once you do have coronary heart failure, diet and exercise are still beneficial. In fact, patients who have heart failure, exercise regimens are not contraindicated. We highly recommend it. It helps with their functional capacity. It helps with the heart health. So I highly advocate for exercise. As far as diet, that's a big conversation in itself. There are certain diets that have been shown to be somewhat beneficial. You may have heard of the Mediterranean diet, the DASH diet. Intermittent fasting is the big big thing nowadays. And I think like no matter what, it's just emphasizing, hey, we need to be healthier with our diets. We need to take care of our bodies. We need to make sure that we're putting the right things into our bodies. So as long as we are mindful of that, I think that it will be beneficial as a society.
Okay, so another comment, very informative and helpful. Thank you. So if there's no more questions, I want to thank everyone for coming tonight and remind everyone this is the last class for the fall semester. The next class will be on January 13th next year on depression, anxiety, and substance abuse in the mature population. So thank you for coming tonight, and we'll see you next year. Everyone have good holidays.
Thank you. Happy New Year.
Okay. Just shutting down here. Okay. Well, thank you for coming tonight. That was very informative.
Thanks, Bill.
Okay.
All right. Have a good one. Happy holidays, everyone.
Okay. Same to you. Okay. Bye-bye.